to a podcast that could be a masterclass based on the life journey of someone who's led his life by example. My name is Arvind Narula, and joining me today is Padma Shri Dr. Shri Mahipal Sachdev, who's not only an ophthalmologist but someone who pioneered the concept of private eye care hospital chain in India and is the founder of Centre for Sight group of eye hospitals in India. He's the one who pioneered phacoemulsification surgeries in India. He's someone who pioneered doing the bladeless surgery, which is called the eye LASIK in India. He's also the first to install Zyoptics in India. Let's speak to Dr. Mahipal Sachdev on a special podcast with Arvind Narula. So welcome to this conversation, Dr. Sachdev. Thank you so much for taking our time.
Pleasure.
Dr. Sachdev, I was watching one of the conversations online, and I remember you saying that when you moved from AIMS to start your practice, you started it because you wanted to make your practice bigger than that of an individual.
Well,
Right? What led you to this thought?
so what led me to this thought was that basically when you are in AIMS, there's an established organization that is there, and it's already reached a particular scale, and as an individual you are able to create your own identity, but you are not able to create a separate institution. So whenever you want to create something that's a legacy or an institution for which it is recognized for certain values, etc., you obviously can't do it alone. And that has to be the aim, that you have to be subsumed within the broader umbrella of the institution. So that's what I thought, that if I can create something within healthcare, specifically in eye care, that institution should have a bigger name than my own name, and that should attract talent, and it should attract obviously the patients to come into that particular organization because of certain values, ethics, and delivery of quality eye care. So that's what I said, that it has to be bigger than my name, and it has to be something that is recognized by itself. May start as being recognized with me, but as you progress along the growth path, you constantly keep downgrading yourself, downgrading in the sense that in the importance ladder, and the overall institution or the organization becomes bigger than you.
Dr. Sachdev, what do you think
Okay.
is the purpose of a private healthcare institution? What do you think the private institutions can do better for the patients than the government-run institutions?
Okay, what I feel, there are several advantages that are there for private institutes. The first thing is that the decision-making matrix is much faster. It's more organized, it's more professional, and you don't have red tapeism and bureaucracy coming in from a point of view of decision-making. In government service, there is a step ladder kind of a pattern for manpower, that this person can fit into this scale and then he gets the yearly increment and things like that. So therefore meritocracy being rewarded often becomes very difficult. The third important thing is that there are people who would want their services to be more professionally given, in the sense that you come to a particular place, you have an appointment, you want a particular thing, you don't get into again the rigmarole of the whole thing. And what I will say is that with more of money coming into the private sector, our ability to buy equipments and technology has become better than government institutions. There is no accountability or least accountability when you are buying, say, a heavy ticket equipment. Supposing I'm buying a LASIK, or I'm buying something which is 4-5 crores of femtocataract for that particular matter. It is coming from the taxpayers' money in a government institution, and there is nothing like a return on capital, etc., those kind of things. So there is no answerability on that. So your decisions to do a particular thing or not to do a particular thing is not guided by any thoughts, in the sense, if there is a technology, like for example, I was in AIMS, if there is a technology that has come, So that has to be taken, and I can say for sure that we are able to even get the technology much quicker, much faster, and at a lower cost. So I think the delivery therefore has improved. The options which were not there for doctors in the private healthcare has improved. So you can get good quality doctors, you can get good quality technology, you can get good ambience, you can get a good throughput for the doctors. So I think that's what the private healthcare can do better. And people over time have now realized that somebody has to pay for your services. So the penetration of managed care is increasing every day. The government has also come out with a scheme. Obviously, we would want the prices to be better, but still, there is somebody who, instead of getting it done free, the government is paying, say, in the Ayushman Bharat and things like that. So I think the private healthcare has to fill in this huge gap between demand and supply. If I just look at, say, ophthalmology, there are about 25-30,000 ophthalmologists, maybe 30,000 in India, and you see that's a 140 crore population, and everybody from a child to a person, an old age person, they all need eye care. So the logistics are very twisted, and the government cannot do this. And majority of the government institutions are not well equipped with new technology, or even if they have bought technology, the maintenance of those technologies is not there. So I think the government has also realized, everybody has realized that the private institutions are going to play a very important role, and they are playing a very important role in the delivery of healthcare.
Also, all of this comes at a cost.
Yes.
Do you think the private sector can do all this, ensuring access and the quality, and make it affordable over a period of time?
See, it is definitely much more affordable than what is there in the Western countries. There is more frugality in the private sector here as regards utilization of various equipment, as regards the consumables, the cost of good, manufacturing in India, etc. So those kind of things. And there is, see, again, it's a question of capacity constraint. So fortunately, we are in the single specialty where there isn't a capacity constraint as regards surgery. Our capacity constraint comes more as the OPD, because that takes a longer chair time. You have to dilate a patient and things like that. But a surgery like a cataract surgery or maybe a refractive surgery, we can do in 10-15 minutes flat. And the revenue that you generate from that is pretty much good. Even if you are looking at lower revenues, which you get from Ayushman Bharat. So if you look at the famous book by Prahlad, C.K. Prahlad, Fortune at the Bottom of the Pyramid. So they have dedicated a chapter on Arvind Eye Care. Arvind Eye Care allows the patients to choose whether they want to get it done free of cost, they want to get it done at this price or private ward, etc. And majority of the patients are now gravitating, or a lot of patients are gravitating towards the paid thing. So there could be a cross subsidization also. So I don't think from a single specialty perspective within ophthalmology or even at a multi-specialty, because there will be enough more people who will be paying. So for example, in airlines, you had a 1 rupee ticket being sold. Obviously that airline went best, but the point is that they do a surge pricing. We can't do that kind of a surge pricing, but still you have the tier system. So when you go to a private ward or a super deluxe or anything, they will be kind of cross subsidizing the lower end.
Or probably there's a differential pricing that is expected to come into healthcare.
Yes.
Where the quality of the treatment does not change, but the facilities that come alongside, you pay for it. Is that what you're hitting?
So that is something that is going to happen, because if you do somebody, say, in the OR, that's where the major delivery is in the patient point of view. Obviously, the charges could be different for people who are admitted in different wards. Right. So that's what's going, there is going to be a tier system. So there is something that's going to fill up the numbers, and there's something that's going to give you profits, and there are some kind of patients who are going to give you super profits. So ultimately, see, it's not going to be a super duper profit making. Healthcare is not going to be that, but it's a service industry which is going to give you sustained results even in the worst times or even in the best times. So if you look at the healthcare industry, there they may have small little blips, but it's not going to go down, and nor is it going to go like a unicorn. Yeah, yeah, it's not going to be a hockey stick.
Being a doctor,
Yeah.
was it easy for you to transition yourself in the role of a business leader?
It's not easy, nor is it difficult. I would say it's just a question of majority of the business is general knowledge. So it's a rare sense, I would say, a general knowledge or a general sense as to how to do things in a proper manner. That's what one has to learn, and we have learned along the way. I do regret always that when you're doing medicine or super specialization, there are no courses like an MBA person would go through. So yes, there is a transition, and I think what is responsible is that I would always read two business newspapers. For there was one earlier, and then the second one came in, and that's something which is a must for me to read, and some books also that I tend to read. So that's how basically we developed the business sense. But primarily when I went to US for my fellowship 89-90, that's where I also found that despite it being a university or a medical college or whatever it is, each department, and within that department every doctor had to fend for themselves. Basically the point is that fending for themselves means that you have to generate X amount of revenue, whether you do it through research or academics or whether you do it from patient care. But then the whole system works around them to be sustainable or to be profitable. If you are making losses or you are not able to meet your costs, then you are booted out. Okay, so basically that was the kind of thing that they were always on their toes to get a research grant or to do something or the other extra so that they are able to make the ends meet. And that's what, as I would say, translated also in my thought process, that you need to be able to put the bricks together so that you are able to build up an organization based on profitability. With the grace of God, despite COVID and all, we have always been as a company been in the black, and we have always been able to generate profits.
But sir, that's true for even a standalone practice.
Yes.
At the end of the day, you have to pay for your electricity bills, the water, and your TNs. But when it comes to running an institution, you have to go beyond that. You have to fend for others as well. The non-medical roles. Did you at any point in time feel uncomfortable initially when you were looking at that admin side?
Basically, I would say that's your DNA. And from a DNA perspective, I would always be doing something more than what was supposed to be done or what was expected of me, whether I was as a student or as a faculty or whatever one may say. For example, when I was a student in All India Institute of Medical Sciences, our group started what is a fantastic uh, students festival called as Pulse. So Pulse is pretty big. So again, we used to have in All India Institute an intermedical sports competition only. So we kind of changed it, got an academic literary festival along with it and a cultural festival along with it, and opened it to non-medical colleges. We had the first fete in Ames, first jam session, first rock show, first fashion show. So those were the kind of things. And when we were in the faculty, I was pretty much leading the faculty association of All India Institute of Medical Sciences for better opportunities for doctors as regards promotions, as regards pay hike. I still remember I was part of the students union where we sat on a hunger strike, and otherwise I didn't, but that was a 35-day strike outside Mr. Rajnarayan's house, who was then the health minister, and our stipend got increased from 350 rupees to 450 rupees as an intern. So the things was to get things organized, put it together, and get moving. I think that's ingrained in my DNA, and that's part of our school. I would again owe it to modern school because the principal, Mr. M. N. Kapoor, would also always look at all-round development. So I think that's about it. My wife played a pivotal role. She left her job. She put in her papers after she had completed 20 years in central government health scheme. So, and then right from the beginning, I was wanting to get talent in. So we did, though out of my, so initially getting the talent in for doctors of various super specialization within ophthalmology, and then getting in talent for operations, for the business development, for COO, etc. So those are CFO also. So basically that was the thought process. I did create a team, and at times I would pull my hair as to literally say when I go back home that well, this is left, this is left, this has to be done, or this could be done better. But I think again, I had a very clear understanding when my wife came in that getting in patients was my job, taking care of them was her job, operations, and then surgical part was my job again, or our job, and then that's how we kind of divided the things. But yes, things have played along.
But before I move on with the interview, sir, when you were at AIMS,
Yeah.
and you said you were to do a lot of things, and you're talking about pulse,
Yeah.
was there something apart from your studies that interested you? Some music, dance,
Oh,
art, or
sure
something?
enough. I was a sports guy in the sense I was always in the, I was in the badminton for the national, Delhi nationals, etc. from modern school. That's I played through this thing, racket sports, whether tennis, even volleyball, etc. So sports was very, I was very much interested in that. Debating was also my strong point. I'm not, I did try my hand at guitar, but I didn't succeed. So I'm not a, I love listening to ghazals and things like that, but I can't sing because I'm not even a bathroom singer, I would say. So there were all those extracurricular activities, and this basically one of the big politicians at that particular time told my mother and my father that you should make him get into politics. So that's leadership.
Was it this type that you
Leadership maybe at that particular time. It was.
one thing, these extracurricular activities
Yeah.
that you were a part of while you were studying,
Yep.
do you think these played a role in your holistic development that led you to think differently from a typical doctor and build an institute?
100%, I would say that's what I said, all round development right from school. Even I would say that I was a avid bridge player. I don't get time to play. We won the Masters. We were the runners up in the Masters in Rendezvous. That's the IIT festival for the master players. That also gives you an insight as to how to plan things, how to play, and how to win. So I think all these things do shape up your mind, and it gives you the curiosity, or it then gives you the insight into how to play a deal, I would just say. So making a good organization or a good business is like playing a deal. So you have to say as to what things are. But yes, the most important thing was to have solid foundations. There was no shortcuts in having solid foundation in what you knew, what you could do, and what you could deliver to the patient. That has never been. And again, I would say it's God gift. I would say. Whether you can do a good surgery or not. There are some people who can do, and there are some people who cannot. My father always would used to say that I have long fingers, and my writing was horrible. So he said it's either of a painter or somebody, but then also of a surgeon. So I think all those things have played a important role in the whole thing. But looking at things from say 30,000 feet height is more important than just being micro or tubular. So until of course you are doing everything, you can't have a broader kind of a, yeah, Mount Everest kind of a down kind of a look. Yeah.
And Dr. Sajid, people like you, in my opinion, but what I have observed, like to do things their way, you know, and they have a certain vision and they want to work towards that vision and they have an idea as to how to make it happen. But then, as and when people come in and join in that force, as a force multiplier, for example, the investors, you have taken multiple external investments. The last week, I think about $100 million from Chris Capital. Has this ever made you feel that your hands are getting tied in terms of taking decisions? or building an institution your own way. Have you ever felt tied up because of these investors coming on board?
Again, I will say I've been rather lucky. Maybe my hard work and my persona and my thought process, whatever, would weigh very heavy on the investors, and they would believe in the story because they came in because of the story that I created, and obviously they talk to you a lot many times as to what you want to do. So as long as your goals are aligned, or as long as you're not looking at cross purposes of this thing, so they normally don't want to interfere because you are still an important peg in them making returns on their investment. So I've never had a kind of a kind of a difficulty because all of them believed in me as to what it is. And then I normally have a very tiring work schedule of maybe about 12 to 13 hours a day. So they see that you are working, you're always thinking, you're always getting ideas, because the business growth may be from a acquisition or a merger standpoint, a brownfield kind of a thing. The inorganic largely is also dependent on me, because it's a lot of doctors coming into you because they know you. Okay, so that's so far I have not had a kind of a thing, but yes, there have been great suggestions by several people, and that has helped me. We have worked very synergistically, and I have been able to give reasonable to good exits to all my investors. The two of them, like 3 rounds we have had, but one was by the same investor. So all 3 rounds they have got exits.
Who's Dr. Mahipal Sachdev at the inner core? An ophthalmologist or a successful business leader? And the reason I'm asking you this because, I want to basically get into that. Have you ever been at the crossroads where you have to make a choice between, your Hippocratic approach, oath versus running a profitable hospital with investors trying to put pressure on you to focus on the profitability or increase the profitability? Has there ever been, have you ever been at those crossroads?
Not really, and this I am staying with a strong conviction, because I personally believe that there is something called as good money and bad money. Unfortunately, you can earn money by being devious, and that's what I will call bad money. Unfortunately, healthcare has been always been bashed and things like that. Maybe there's some truth in there, but if you are delivering quality care and you are transparent, the patients come to you. For example, if I have to price my surgery or whatever it is, I know what I'm going to price it at, and that's transparent. So we don't discuss costing, etc., with patients as a doctor. It's discussed with the counselor, and the counselors do not have the leeway to change things, etc., etc. So profit follows good results and good outcomes. So if you are giving good results, you are giving good outcomes, a profit would follow. So we have not been able to kind of understand the basic in healthcare that quick profits are short term. They won't stand an organization in long term. So that's what you have to understand, because you are it is not a sprint we are doing, it's a marathon we are running. So you have to conserve your stamina, you have to conserve your reputation, as I will say, that's your skill sets, etc., and what you stand for, to keep on getting the patient flow. So we kind of work on that, and I don't think even in the worst of times there have been, see, if you are degrowing, everybody will get at you. Your investors will get at you, your shareholders, everybody will get at you. But if you are maintaining a good CAGR, you are maintaining a good growth. So I don't think they have anything to complain about.
I love when doctors are talking about these terms like CAGR. But it is interesting. But Dr. Mahipal Sachdev, when you start an organization,
Yes.
your first few people who come and join you in your vision play a key role. And I'm married to a doctor. She comes from a family of doctors, and I've spoken with about 250 doctors in the last 3 years.
Good.
Doctors are very cautious about their reputation. They have a little bit of a, if I could loosely use a term, I don't know if it's correct, but they have some ego in their growth. And I'm not using it in the negative sense because they have to build their practice and perception in the industry. Have you ever felt that the senior doctors like yourself, who you want them to become a part of your organization, feeling that, I would want to, I won't want to work under another senior doctor. Have you ever felt that? And if you did, how did you overcome this precondition in their mind?
So the first thing that I did was that I made a neutral name. So I knew you have mildly said it. I think doctors are super egoistic, and वो मेरा patient या अपना patient या जो कुछ भी है, they want to preserve that. Correct. Because they are looking at building their practices. Correct. They are not looking at building their institution or an organization. That is the most important thing. So if my goal was set right from the beginning that the organization has to be bigger than me, so one would kind of give way. The second important thing that came in was the help that I got, that within ophthalmology there are super specializations. Okay, so within super specialization, I could get people, A, by having a neutral name, B, by taking the risk and the ability to offer them much more than they were getting. And then the point was that they were cherry picked, or I would say that they were hand picked, and they were people who were like me, graduates and postgraduates and faculty from AIMS. But they were from a different subspecialty or super specialty of ophthalmology. So there was no clash. Right. This was clearly understood that if I have a glaucoma patient or I have a retina patient or today a squint patient or whatever it is, I won't do the surgery or anything, but I will tell the patient that this guy does a better work than me, and you kind of show him, and vice versa. So the divisions were pretty okay right from the beginning. Yeah. So it's like a cardiologist sending to a nephrologist or thing like that. ठीक है, a cardiologist can also treat a diabetes, or he can also treat a pulmonology. But then when there are super specialists who can do a better job, that's what we went out to build. So egos are there, but you have to massage the egos and you have to give them the space. So those spaces have to be given, and once you give them the space, and I know that they are doing a better job in that particular thing, then that doesn't come. And it's not a shadow that if I got a retina patient, I will book the patient on my name and ask my retina guy to come and do the surgery for me. I'll tell the patient that I am not a retina person. This guy is a retina person. I have super confidence in him, and you go to him. So I think you have to kind of get that this thing. But yes, there are some practices that we have done joint ventures or something like that. So I have told a couple of those doctors कि भैया आप दूसरों को काम दो, क्योंकि under a banyan tree you can't have another tree growing. So because you are big there, and they don't, and it's a chicken and egg story. You don't get good doctors till you get them the work to be done. ओके तो आपको अगर काम ही नहीं मिलेगा तो यू आर नॉट गोइंग टू ज्वाइन. अगर वो कहेगा कि आई एम गोइंग टू बी अंडर द शैडो ऑफ दिस गाय, देन व्हाई वुड ही ज्वाइन? So you have to give them the independence, you have to give them the equipment, the technology, and you have to have their name promoted for that particular thing. My simple concept has been that if a doctor comes and joins you and he grows in his name, there is no way he can grow without growing center for side along with it. Right. So it's both the things are happening simultaneously.
So you've been able to create a sense of belongingness to the institute, to the institution.
Yes.
Yet give them space that this is their space.
Yes.
Fantastic. And so, one of the biggest challenges that we've seen or heard of in the healthcare practices, when patients complain that a doctor does not devote too much of time. हम आते हैं, डॉक्टर बात करता है, वो सुनता ही नहीं हमारी बात. That's a very common complaint in the healthcare industry. And now technology development, technology advancements are even making it worse, because the patient at many times does not even require to come to the doctor. I don't know how much of it this is the case in the field of ophthalmology, where the person has to come and show the errors. But do you think that there is a time where the doctors need to cautiously think about how they can balance between the technology advancements that are taking place versus the patient centricity, or I would call it that the personalized patient care that needs to be thought of, and how, because this is going to become worse. I mean, today we're talking of remote monitoring, remote testing.
So, you have to kind of dissect and slice out these things. The first particular thing that you have to say is that there is a concept of healing by touch, in the sense कि भाई patient आया, वो बीमार है, या he has a chronic problem like asthma, or maybe a heart problem or a BP problem, etc. So or maybe he's suffering from anxiety or depression, and that's where talking also becomes very, very important, right? But then the idea there is that, for example, if you're looking in Middle East, say in a Dubai or in other places, there is a restriction on the number of patients you can see per hour. आप इससे ज़्यादा पेशेंट हो, आपको स्लॉट ही नहीं कर सकते. So that is something where, but the point is that one consult is equivalent to X thousand rupees. Okay, so at the end of the day, the population is less, but they are having a higher GDP and they can afford more. So it balances out, and then medicine still remains a good profession, and from that perspective. But here you have to play by the numbers. So ultimately, at the end of the day, if we have to be profitable or we have to be doing this thing, unfortunately, एक तो पहले उम्र लग जाती है 45-50 years, तब तक आपकी रेपुटेशन बनती है. दैट्स व्हेन पीपल कम इन टू यू, एंड दैट्स व्हेन इफ़ यू आर तो वो कहेंगे बच्चे से ऑपरेशन. इवन टुडे पेशेंट्स कम के, सर आपका इतना हम सुना था, आप तो बहुत यंग लगते हो. मैं कहा ठीक है भाई, यंग लगते हैं तो मैं क्या कर सकता हूँ. दैट्स, I think there has to be a matching of what country you are working in and where you are working in. One, again, a lucky point of ophthalmology is that it is intervention. OPD doesn't give us the kind of revenue that you are looking at. It's intervention. And intervention is very fast. तो टाइम तो देना ही है सर, वो तो उसमें मतलब इफ़ आई हैव टू डू अ सर्जरी 7 minutes, 8 minutes, 10 minutes, दैट्स फाइन. बट देन दैट गिव्स मी द थिंग, एंड द पेशेंट वोंट कंप्लेन देयर, बिकॉज there is no healing by touch there. It's healing by technology, it's healing by equipment, it's healing by surgery. So that is where there are a lot of patients who are very happy. They say कि भाई सर्जरी आपसे करवाने आए हैं, that's it. उसके बाद I tell them, because I have multiple centers, I tell them please don't crowd here. You save your time, you go to a center which is near to you. Like 30-40% of my patients are from outside Delhi. So I don't want them to do a 1 day, 1 week. 1 day, yes, I'll love to do that, but a 1 week and a 3 week post of follow up, I say कि भाई ठीक है, आप पटना से आए हो या रांची से आए हो या कहीं से भी आए हो, मध्य प्रदेश से, you go and show to our center there, and our doctors will see you. So that's the kind of you have to get away the importance of a person being the only care deliverer. तो टाइम दे सकते हैं आपको दूसरे लोग, बट येस अनफॉर्चुनेटली देर इज़ अ काइंड ऑफ अट्रैक्शन टूवर्ड्स अ नेम के लॉट ऑफ पेशेंट्स वुड गो देयर, एंड देन इफ़ यू आर अ बिजी डॉक्टर यू मे नॉट बी एबल टू गिव द टाइम. But then if you tell the patient that the criticality of a particular thing is being done by you, that serves a lot of purpose. This is often said because by the time the patient comes to me after workup, first going to the reception, then going to the optometrist, then going to the doctor, then going to the retina doctor and coming to me, so they say कि sir आपके पास आने में बहुत समय लग जाता है. So that is a problem. But then the point is that at the end of the day they are also satisfied that it has been a thorough checkup. And the criticality of the thing कि भाई आपको ये diagnosis है, ये है, and this treatment, that is done by you. But yes, technology is going to change. See, there's a simple thing that has been done by one group in China, where before a person comes to a doctor, 50-60%, 70% of the time consuming things have been done. So you are auto-filling your demographics, you are auto-filling your number, you are auto-paying, you are also doing your history. कि भाई मेरे को क्या बीमारी है, कब से, etc., which is normally taken by either a paramedic or by the doctor, and they have to keep on typing. सो आपका अगर ये सारा कुछ ऑलरेडी उसमें है, तो देन यू आर सेविंग, मतलब दे हैव शोन दैट द चेयर टाइम और द वेटिंग टाइम बिटवीन अ पर्सन लिविंग होम एंड गेटिंग आउट बैक होम, that is reduced to half. So appointment fixing is done online, payment has been done, demographics has been done, previous appointment वो आपका chart already pull up हो जाएगा, this is the new history, this is what I am having, etc., those kind of things. So you have to find out ways to conserve time.
अभी जो बात करी हीलिंग बाय टच और हाउ द डॉक्टर इज स्पीकिंग टू देम, यू नो, किस तरीके से बात करी, किस तरीके से उस पेशेंट को कॉन्फिडेंस दिलाया, फेथ हो गई उसको. You know, you mentioned that in the medical school, nobody is teaching you how to do business, right? At the same time, do you think there is a need for medical school to also teach you these soft skills that can bring comfort? Is this being done, or?
No, see, business is a separate part. This is bedside manners.
Correct.
So bedside manners is always taught by some doctors. Matlab, our seniors would say that this is how you should, etc., etc. So yes, there, but it can be reinforced or it need to be emphasized. See, the point is that when you are in a sarkari, nowadays you are having private medical colleges, so maybe the thought process might have changed. I have never been to a private medical college, but when you are looking at a government medical college, वहाँ पे आपको patient का इंतज़ार नहीं करना पड़ता. So the point is that you are already getting a steady inflow of things that's coming in, and you don't have to. But when you are in the when you are in practice, you actually have to get the patients coming to you first. That is the first step. Then you have to do delivery. So इसलिए वो, that is very important that the follow-up patients, like when we do our NPS scoring or whatever it is, we will want to see also the new patients / follow-up patients. The follow-up patients should be at least double the number of the new patients. If you are not tracking the follow-up patients or they are not coming back to you, that means there is something wrong. Right. You might be attracting new patients by whatever means you are, but at the end of the day, a patient who has come to you and he is satisfied, he has to come back to you. Absolutely. So the follow-up patients have to be double of at least the new patients that you are seeing, and bedside manners have to be taught more aggressively. What you have talked about, there is also a confidence level that a doctor exudes. That is very important for the patient to know. अगर आप फंबल करो, यार ये करूँगा तो ये हो जाएगा, ये करूँगा तो ये हो जाएगा, the patient wants you to be somebody with an experience who can say कि नहीं, we will do this and you will be all right. Like nowadays the problem is that the consent forms are so huge because of the litigations etc. that have come in, that the patient often gets psyched. ठीक है, आप प्लेन में जा रहे हो, एक्सीडेंट हो जाते हैं, कार में जा रहे हो, एक्सीडेंट, बट व्हेन यू आर बाइंग अ कार, यू आर नॉट गिवन अ कंसेंट फॉर्म टू साइन के भाई मेरे इसमें एक्सीडेंट हो जाएगा, सीट बेल्ट फेल्ड हो जाएगी, दोज काइंड ऑफ थिंग. सो दोज आर थिंग्स विच हैव taken, I would say, a negative kind of a downtrend. But if you are giving a kind of an advice to a patient and you are having a confidence, that only comes from your inner self. अगर आप किसी चीज़ में पक्के हो, if you are rock solid in that particular thing, then only you can exude confidence. फर्जी कॉन्फिडेंस पेशेंट एकदम पकड़ लेता है.
कैसे होता है? Because I'll tell you what, I mean, एक बारी I remember we were doing a conversation and the conversation led to discussion of good doctor versus an honest doctor. You know, and then the dishonesty was not in terms of just profiteering from a situation that the patient was in, but also not developing your own skills or upskilling yourself when you are ways of surgeries, new therapies, technologies that are coming in. You know, and that is something that we found that a lot of senior doctors, वो अपने आप को नए robotic में, for example, या AI में train नहीं कर.
ट्रेन नहीं करेंगे तो ख़त्म हो जाएंगे सर. आई एम वेरी क्लियर ऑन दैट. मतलब वेन एवर आई हैव अडॉप्टेड टेक्नोलॉजी, आई हैव ऑलवेज बिलीव दैट इफ द टेक्नोलॉजी इज गोइंग टू वर्क, एंड दैट्स गोइंग टू बी माई ब्रेन एंड माई गट telling me that this technology is going to be work, I lay my hands on it first. Right. Okay, and that's because see, if I look back at the history of Centre for Sight, there are two things that has made very, very significant contributions toward where Centre for Sight is. One is the art of phacoemulsification, that is the no-stitch cataract surgery, and second is LASIK. Right. I knew that these two technologies work. When I had gone to US, I had seen one of them, and the second one also there was discussion on that particular thing. So that's what I wrote the technology. you needed to be different from others. You need to have a USP. You can look at any doctors. You can say, look at NT Naresh Tehan. He started cardiac surgery in India. You look at Chaube, laparoscopic cholecystectomy. You look, you name it. The comment is that this guy, Chirian or anybody cardiac. You have to. So when I left AIMS, I had made a blueprint that this thing I will do in 1 year, 2 years, 3 years. So I said I would be doing 30 cataracts or 30 surgeries a month after 3 years. And I did that in the first month. That was the kind of the underestimation that I had of myself. But the answer was that because I had the skill set and people knew that that was a skill set which very few people had at that time of phacoemulsification. So that's what the first patient came in. He said, "Sir, मेरे को book करो." I wasn't even prepared on the first day to book a surgery. So if you do not adapt to technology, and technology has come so thick and fast within ophthalmology, that पहले कैंप सर्जरीज और घर में सर्जरीज होती थी, and now it is all high tech, robotic, etc. If you are not adapted, it's going to be bad. I still remember my wife, like we knew each other from, we were together in pre-medical. And when we were engaged and my internship was to start and things, and she asked me what kind of what specialization are you going to apply for, and I said ophthalmology. So she said, "भूखे मारोगे." Because ophthalmology was a poor man's thing कि घर जाके सर्जरी करते थे, उस टाइम टेक्नोलॉजी नहीं होती, कैंप सर्जरीज वगैरह होती थी. So things have so dramatically changed, and they have changed so dramatically because each and every part of the eye can be visualized by some imaging technique, and you can deliver specific lasers. There's huge amount of lasers in ophthalmology which are focused and giving results to these different disease processes. So that's what is technology got into it, and every day I talk technology. We go to conferences to see where the world is moving. अगर आप adapt नहीं करोगे तो खत्म हो जाओगे.
And so where are we thinking now? Because this is a super specialization.
Yeah.
And are we seeing overseas patients coming to India? And what is the future of eye surgeries in India?
Future, I think it's a very good specialty to be in, and the specialty problem is कि आप बच्चे से शुरू हो जाओ. आप प्रीमेच्योर बेबीज़ को ज़िंदा रख रहे हो, उनको you give oxygen, they end up with retinopathy of prematurity. Okay, so that's a disease process. You grow, people are being born with congenital defects, etc. They can be born with squint, they can be born with congenital cataract. So that's right from there. उसके बाद ये हमारे gadgets जो हैं, incidence of myopia is increasing. Children are getting on to wear glasses. If you look at Japan, Korea, Taiwan, Singapore, Hong Kong, China, etc., the incidence of myopia is about 60 to 70%. In India, it's still, I would say, about maybe around 30%. There are no exact numbers, but 25 to 30%, and that's going to grow. We saw it in COVID when everyone was locked in. The incidence of people just working on their phones or computers, etc., that went up, and therein the myopia comes in. And then you have the children coming in into the adolescence or going into this thing, and then they have the urge to get rid of glasses. So you have laser vision correction. Laser vision correction is booming in these countries that I named. In India, because of the affordability, the penetration has increased significantly, and I still foresee that it's going to keep on increasing. And then you have the people needing to wear glasses, etc. Maybe the 30, 25 to 40, 45 years, you don't have any major disease that comes into the patients. But then you start having people developing the need for reading glasses. Today there is a lot of work being done to remove the need for reading glasses. So that also, whether it's laser vision correction or a refractive lens exchange, that's going to happen. And then as you age, you're going to develop cataracts. And that's going to happen to everybody until, of course, we have a magic drug to stop aging and stop the onset of cataract. So then diabetic capital, we are longevity also is having effect on the retina. So diabetic retinopathy, age-related macular degeneration, so those things which were at times non-treatable earlier have now become in the treatable domain. So starting from the cradle to, I would say, the grave. So you have that, and there is 140 crores into 2, so that's 280 crore eyes. 32 दांत नहीं है, but anyway you have 2 eyes for every person, right? Yeah.
Listen, let me come back to the institution that you asked. आपका एक thought process है. You have your very clear-cut focus and you're known for that in terms of focus on quality, focus on excellence. Now, as an institution, you have to have this cut across at every level. Every doctor in the institution has to have that focus on quality and excellence for the institution to grow. How are you doing this so that your vision, your way of working, your vision is being aligned with other people who are working in the institution?
So I think the first and the foremost thing was the hiring process. In the hiring process, we are very keen to have people who are done their residencies or fellowships or their further training or faculty from great institutions. Ref check is an important thing. A surgical demonstration of their skill is also important. So those are the things. So that's the induction phase. Second is that there is a DNA running through the organization. There is zero tolerance for wrong work. So that is loud and clear to people, and we have never forced them to do something. The only thing we tell them is that if a patient has to get a surgery done, then if he doesn't get it done from you and gets it done from somebody else, means that you are not either a forceful doctor or you are not able to convert. So those are the only things that we tell them, these soft skills as you were talking, that how, or the counselors as to how they are converting. But otherwise, and then every adverse event that happens during a surgical procedure or anything has to be noted, and it is actually escalated up to me. So I do get a mail that this kind of complication happened, and then we do a medical audit and we look at what the outcomes were, and then we compare it with the outcomes that are there. So that is a percolation of the whole thing, and if somebody is not working up to the standards of what you are expecting out of a good doctor, then we can call them over to the parent organization here in Dwarka or in Saptaring Enclave and tell them that this is how things are. We have our own fellowship and residency program, and then we are taking those guys on board, those we find are good out of them. So that's how you maintain the quality and the whole thing, and at the end of the day, if things are not working out, I just say that the doors are wide enough for somebody to walk out.
This brings me to a very important question that in every organization to grow and become consistent with quality and outcomes, it is important that the errors need to be reported.
Yes.
And most of the time the errors do not get reported because they're like, patient को पता चल गया तो क्या सोचेंगे, टॉप मैनेजमेंट को पता चल गया तो वो हमारे बारे में क्या सोचेंगे. How do you as a leader of the hospital ensure that the team is encouraged to share it for the right purposes so that you can make the processes better without the doctors being fearful of not wanting to report the error?
See, there are certain checks and balances. The first thing is that there is an adverse event register in every OT. So I'm talking mainly about OT, OPD का ठीक है, मतलब that's fine, but so that has to be entered. The second thing is that if you have an adverse event, typically you have to go in for some kind of re-intervention. Okay, so no patient can go into the OT without a zero billing. Okay, so if I have a re-intervention, we may not be charging the patient, but then the patient has to have a 1 rupee bill. Okay, so that enters the system. Right. So if there are zero billings and those have not been reported in the adverse event, so obviously there is this thing. So we have the MS and the DMS, etc. that's there, but ठीक है, मतलब we trying to keep that, and the point is not to, when we do the medical audit, we kind of say that these are the complications or these are the things, and medical audit and then a medical review, okay, what could have been done better and things like that. So जिसको ज़रूरत होती है, we'll try to say that. There are some people who are not great surgeons, and as I said, at times you might have to really...
One of the things that has not got enough attention in the past in our country is research and development. Uh, you mentioned that your hospital has fellowships, etc. How are you focusing? Are you doing R&D to make, for example, not just doing surgeries, but also making better processes or some technologies or therapies that could come out of your institution? Is there an effort towards, conscious efforts towards making that?
Yeah, there are conscious efforts towards making that. There's absolutely no doubt about it. And the conscious efforts are that every fellow or every DNB resident, etc., has to be given a thesis topic. And that obviously the thought process comes from the seniors, and that is where you want to do that. Then we have international research coming into it, and you have to focus on that. And there is enough and more. Like we have our institutional ethics committee, our scientific committee, and things go through that process, and then we do that. But I think yes, we as an organization can do a little more in R&D. The only thing is that R&D funding is not that easy in India. And with Trump having cracked down now on NIH funding, etc. So I don't know, because there was a lot of funding that was coming out of US. See, ultimately, industry has to invest in research, and they have to do something which kind of gets them. You see, the most cash-rich people today are the pharma industry, because new genes, molecular therapy or whatever they are looking at, those kind of things. So when they invest in that, 10 may say maybe 8 9 fail, but then there is a lot of money that goes into it, and then you come out with an invention and things like that. So we as fundamental research is not being done to that extent in India. Fundamental research, I would say that you throw a hypothesis कि ये चीज़ है तो इसका ये होगा तो ये इसलिए काम करेगा या नहीं करेगा, तो उसको then you have to prove that. So that doesn't happen to that extent. It's more clinical application that's happening. So that's a different form of research, but it is there कि भाई ठीक है, somebody else is developing a technology or this thing, they'll say whether it works or not, and then whether it works in India. Nowadays, when a drug has to be approved in India, etc., you have to have certain studies to say that it is working in Indian population. There are some countries that they have now agreed to say that if that is approved in XYZ country, then you don't need the re-validation of the same medicine. But yes, research and development, ultimately the big guys have to, or the pharma industry, etc., have to push in money within India to do that. That's happening to a large extent in US, and that's why they are ahead of us, Europe also. So that's where the brain is thinking कि ये करूँगा तो इससे ये solution होगा, but somebody has to put the money into.
आपने अपना institute खोला and you've grown it, you successfully brought it up.
Yep.
What are the common mistakes that you feel? I'm sure you must be observing other doctors also setting up their own practices, trying to make it big.
Yep.
What is the common mistake that you've seen most of the doctors make when they're getting into an entrepreneurial role in terms of setting up an institution beyond their standalone clinic? क्या चीज उनको नजर में रखनी चाहिए when they are getting into this role?
Gold's very good.
So कैसे होती है?
You are just a peg in the whole story. You are not the story. That is the important thing, that you have to have the other building blocks come in to create a story. And they don't think beyond themselves. That's point number one. Point number two, you cannot be doing everything yourself. Hardest thing to get is to create a team. That's the best investment that you can make. The people don't do that. That's the other mistake. सब कुछ micromanage करना है. उससे दिक्कत. Initially, yes, you can micromanage, but then you have to give way to people who can do things better than that. Third is risk-taking ability. Success and risk, the antithesis to each other. If you want to be successful, you have to take more risks. Doesn't matter, you fail, get up again and learn from your failure and then run again faster. So I think these are the, and then not having the knack to understand that this will succeed. This is what can sell. That is what gives me a USP. So those are the kind of things that people normally lack. And I also did that mistake, was that ophthalmology, for example, See, there is a study that's done that if you have certain kinds of diseases, you can travel. So, if somebody has a cancer, so oncology people can travel up to an average of 250 to 300 kilometers. Cardiac disease is slightly less, maybe 100. Neurosurgery is high, but in ophthalmology, it is basically about 10 kilometers to 15 kilometers. Okay, so people don't want to travel for routine, which is 95% of the bulk of, say, the ophthalmic practice, to go to various distances, etc. So what we kind of have to do is that whether you do vertical or you do horizontal. So obviously, yes, you can do a vertical thing, but if you have to capture a bigger market, you have to do it horizontal in ophthalmology. So the mistake that a lot of people is कि भाई success आपको होगी तो मतलब I should not bleed is the main thing. तो उसमें पहले पैसा people put into buying an asset of a property. So that kind of retards your progress. Okay, so asset light model आपका model है. If you have to make it an asset light, then be it asset light. ठीक है, you are willing to bleed. That's what people are not willing to bleed. So that's how, and given a long enough time, and given good doctors, the word of mouth spreads, and you will break even. But that's one of the mistakes that people make, say, within ophthalmology, or building an asset, just thinking that if I am building an asset and I don't have the doctors and the team, I'll still be able to run it. आपके पास स्किल ही नहीं है और आप कह रहे हो कि मेरे बाप दादा के पैसे हैं, I'll just put it, I'll make a this thing. So that's हॉबी के लिए कई बार लोग आ जाते हैं, मतलब लॉट ऑफ पीपल हॉस्पिटल बनाना है जी, ठीक है हॉस्पिटल बना लेंगे. दैट डजंट वर्क until your skin is in the game, in the sense of your eating, breathing, sleeping, drinking, your organization, like what I tell my people, to do that for center.
Yes. Sir, आपने succeed word use किया है. And I take my cues from there. What does success mean? What does it mean to you? And what I've seen is that success, or the definition of success, changes over a period of time.
Sure.
जब आपने शुरू किया होगा, आपने vision setup करी होगी, and you must have said that ये करेंगे तो I won't succeed. But then goals change.
Yes.
So what does success mean to you today, and how has it evolved over a period of time?
So that's what I'm blamed for by my family, that my goalposts keep changing. And obviously, इंसान की सोच जो होती है वो, when you start out at something, is limited, that this is what I want to. So my thought process was to have an institution where I can deliver quality care in ophthalmology. And that changed over time. Like, so at one particular time, where we have in Saftaring Enclave, that's where I started as a single room clinic. It was a nursing home and I had taken one room on rent. So then once we grew, kept on reinvesting in the business. So my wife and we were going, and I said, if I can get a property on this road. So she said, you've lost it. So again, the thought process was this, and then you looked at there, and then you thought of other centers. Again, they came by chance, but you grabbed the opportunity. That's what it is. Changing. I still remember a close friend of mine. He was head of Bosch and Norm, and he was talking to me, what is success to you, and things like that. I said, if my company is valued at 50 crores, I think I'm successful. From there, it has transcended to today, maybe not today, a couple of years ago, to $1 billion company. But unfortunately, the dollar from 43 has gone down to 87. So the goalpost, the rate of depreciation is something that we didn't take into account. But yes, as you feel what is success, your goalpost keep changing. So success is imaginary. At the end of the day, making money or something is not success. Leaving behind a legacy or creating an institution that is recognized by people for certain particular values is something important, and something that survives after.
What would be that one change that you would bring to the healthcare industry in India? What is that one thing that is a burning need to bring or take healthcare to the next level in our country?
I think it has to come from two things. एक फर्स्ट थिंग इज़ कि जो मैन पावर है उनकी इज्जत को बढ़ाना, कि दे आर डूइंग समथिंग विच इज़ critical importance, and they should not be treated shabbily, because healthcare as a profession is losing its charm. You have these incidents, I don't know who is to be blamed, where people can bash up doctors and things like that. So first thing I'll do as a healthcare is to get the doctors back in the place of the pedestal, and the second thing is to make investments into healthcare. Very clear, if you give peanuts you will get monkeys. So the point is that yes, they have taken baby steps, or they have taken steps where they are paying for the health coverage, but don't do it at the cost of quality. मतलब आप एक चीज़ को निचोड़ सकते हो कि वो, मतलब यहाँ इलास्टिक को खींच सकते हो कि वो टूट जाएगा. सो बेसिकली द प्राइसेस नीड टू बी समथिंग. फॉर एग्जांपल CGHS रेट्स पिछले मेरा ख्याल 10-14 साल से वो चेंज नहीं हुए. सो जस्ट बी रियलिस्टिक अबाउट दैट, do it well, and put GDP into the longevity of people is increasing and their productivity is going to increase. So that's the two things I will want to do, the more investments into healthcare and giving infrastructure status or whatever you want to do, but it should not be from a perspective of only that the big people can get that benefit. That's important, that you need to make people invest in healthcare. That is the biggest thing that I will want to do it. See, आपकी strength जो है ना आज की तारीख में, the number of medical professionals that you are having coming out every year, like the government is doing well to have medical colleges and things like that coming up. So that is a very big corpus. Don't let them go out, in the sense that you provide opportunities for them, and opportunities are provided. There's a reverse brain drain also that's coming. So अगर आप उसको मतलब if you get them their due, that this is what is due to you and this is how you can improve, you can really have a lot of, Bangkok for example, Thailand, that has a lot of medical tourism that's coming. उसके साथ infrastructure development हुआ, सब कुछ हुआ, patient comes, he gets the surgery done and goes. We get medical tourism, that's not a problem. But the government has to invest in infrastructure and making it more profitable and viable. See, private equity money or any other money comes into any business if they...
But when you look at the government announcing that medical colleges seats बढ़ा दी है, सब कुछ करना है, but यहाँ पे the larger issue is that we don't have enough medical professors, the teachers, so how can we
स्विमिंग आने के लिए ना आप छलांग के लिए बस बंदे को डाल दो. The point is that let's not be negative on that particular. I personally feel कि आप उसको करो तो सही, आगे अपने आप रास्ता निकल आएगा. That's it's yeah, it's a, see, the point is that you will be, see, there is nothing, there is something and there is something better and then there is something. So it has to be सबसे पहले आपको ये nothing को तो ख़त्म करना है ना, कि भाई मेडिकल कॉलेज तो आए, सीट्स बढ़ गई है, जो कुछ भी है. बट फॉर एग्जांपल seats were increased in All India Institute of Medical Sciences for various reasons. So we were a batch of 50, but now I think the batch is 80 or 120, I don't know, but the number of seats have increased. So AIMS can easily, as undergraduates, AIMS Delhi I'm talking about, that can easily do 150 or 200 as much as Maulana Azad is doing. So there has to be impetus. What has also happened is that DNB has come in. पहले तो अगर सरकारी medical college है, then only you can teach people. Now we are allowed to do that as diplomate of the national board. People are preferring coming to us than into government hospitals. Like in the NEET exam, if my DNB people, there will be X number of sarkari hospitals where people will not do this because they are not exposed to technology, they are not exposed to good teachers, etc. So I think they have to open up the teaching, training, etc. If people can outside can come and train here, why can't our own people this thing? So medical college, मैं इस चीज़ से I believe that करो, you will again get the people to come in.
And sir, we have been talking about doing the right thing. My personal belief is no doctor will knowingly do something which is not correct.
Sure.
Right?
Yeah.
Their interest is in their patient getting well, the outcome being good. Right? The challenge could be in the business models that are being built in various institutions. How can you as a very senior and experienced healthcare delivery professional, what do you suggest can be done so that a doctor is motivated and inspired to do the right thing despite the uh, the business models that are being sent or thrown at him?
See, it may be true, but if I take our example or whatever it is, I personally believe that a doctor, if he gives a wrong opinion, he will lose patients. देर आर पीपल हु कम टू अस कि भाई मेरे को फलां बंदे ने कहा है कि भाई ठीक है कैटरैक्ट तुम इमीडिएटली करवा लो नहीं तो आंख ख़राब हो जाएगी एंड दे कम टू मी एंड आई से कि ठीक है इट्स एन इमेच्योर कैटरैक्ट इफ़ यू डोंट फील द नेसेसिटी टू गेटिंग अ सर्जरी डोंट गेट इट डन सो the patient may defer the surgery because he wanted to defer the surgery, but then he'll come back to you. So knowingly, again I said short term vision versus a marathon or a sprint, so that's what it is. I don't play a sprint. I don't run a sprint. I want to run a marathon. And that is very important. And then there is this thing कि इंसान को अपने ज़मीर के साथ सोना है. So why would a person want to harm somebody maybe for a few dollars more or something or a few rupees more? I would not. अगर कोई complication होती है ना टेबल पे तो मेरा हार्ट बीट पेशेंट कार्डियक मॉनिटर शुड बी ऑन मी नॉट ऑन द पेशेंट. So that's when you sweat and that's when you say कि भाई why the hell something has gone wrong and you feel and the patient a complication today, that's what I said, डॉक्टर की इज्जत सबसे पहले बहाल होनी चाहिए. A patient thinks कि a complication is equivalent to negligence. I have to be a non-operating surgeon to be complication free. Simple as that. अगर मैं सर्जरी करूँगा तो complication होगी. Simple as that. So the point is that whether I had the adequate skill to do that thing or not is the question. That's about it. And whether I did the right thing or not, but there may be एक रास्ता that is something that one can do at that particular time कि भाई ये चीज़ हो रही है तो मेरे को ये कर सकता हूँ या ये कर सकता हूँ या वो कर सकता हूँ. That's about it. But doctor bashing is something that has taken away the glory of the profession, I would say. And that is what I said that needs to come back. Maybe we are to blame for it partly, but then, there are certain soft targets and unfortunately they get bashed up.
So my last question to you is, if you were to get a diagnosis which has been completely AI driven versus an experienced physician's judgment, what would you want?
You can't wish away AI today because a physician at the end of the day is now today also relying, apart from his clinical judgment, on technology, on diagnosis by say a CT or an MRI or an EEG or a angiography, etc. And AI driven, and AI knows everything at that particular time. There is a lot of data. एंड हमारा दिमाग सीमित है. 64 खाने में बोलता हूँ तो 64 खाने में आपने कितना किस टाइम पढ़ा हुआ है वो उसके ऊपर है. तो AI हैज़ lot of stuff coming into it. So tomorrow, yes, you will believe more in what an AI is doing than what a doctor is doing, because more often than not that's going to be correct. You can't wish away AI. That's what my thought process is.
So, Dr. Sachdev, thank you so much for having a conversation with me. It really means a lot because, I really feel that it is journeys of people like you that the young generation can take inspiration from and also take the benefit of understanding your journey to make it more real for them, to do what they've set out to do. So, thank you so much for sharing that.
My pleasure, Arvinder. Thanks for having me on your show, and let's hope I can be of any help to any young generational guy.
Absolutely. Thank you so much.
Thank you.